Now we'll go over the conduct of transeptal puncture in this patient when we acquired some difficulties in crossing the interatrial septum from the left to the right side, particularly so in optimizing the location in the anteroposterior axis of the interatrial septum. Now, going over the transeptal puncture, the purpose of a safe transeptal puncture is to cross the interatrial septum, that is the true interatrial septum, without going through the extra cardiac space from the right to the left side. Now, there are multiple methods of doing this thing. We conform to the Pitlock protocol that consists of first practicing, then identifying the needle, tracking it, then locating the point of indentation, finally optimizing the point of indentation, and then crossing the septum under direct vision from the left side, from the right to the left side, to optimize and facilitate the intervention on the left side. As can be seen in the simultaneous orthogonal view of the interatrial septum to the heart at a slightly oblique orientation, the superior and inferior extents of the septum are rather long. However, the anteroposterior extent of the septum is very short, implying that the fossa ovalis is very elliptically shaped in this patient, which makes it a challenging anteroposterior septal puncture. As mentioned earlier, due to the elliptical shape of the fossa ovalis, our first attempt at septal crossing led to indentation being produced at an optimal location in the superior-inferior axis. However, the indentation is more anteriorly located than it is posterior, making it an unsuitable site for septal puncture to have an optimal trajectory of the device into the left atrium for a precise deployment of the mitral clip. However, as you can see that the maintenance of this location and of indentation led to a septal puncture which was more anterior than we liked it to be, which led us to revise the transeptal puncture, as you can see in the subsequent video. Therefore, to optimize the trajectory of the device into the left atrium and its positioning above the mitral valve, we revised the transeptal puncture. And as you can see in this video, the indentation produced by the transeptal puncture needle is optimally located not only in the superior-inferior axis, but also in the anteroposterior axis. Significantly, the location of the indentation is more posterior than it was in the first attempt, and therefore the septum was crossed at this location to proceed with the rest of the procedure. There are some important lessons and take-home points from this case discussion about this challenging septal puncture. First and foremost, septal puncture is a procedure that is based on precision, whereas the dimensions of the fossa ovalis are not more than 1.5 to 2 centimeters in either dimension, but it can take a huge landscape if we require precision in performing the septal puncture for a specific left-sided intervention, as can be seen in the graphic. Therefore, it is important to have open communication between the proceduralist and the echocardiographer before and during the procedure to optimize the location of the transeptal puncture. Secondly, the important orientation of the various rims of the fossa ovalis. They are based on the anterior, posterior, superior, and inferior location in relation to the cardiac structures. It appears they are orthogonal, but the actual anatomy is quite to the contrary, and specifically so, the anterior and the superior rims of that is the aortic valve and the superior vena cava, the landmarks that are used to identify these rims, are non-orthogonal, and they're almost side by side. Therefore, it sometimes is a source of confusion and ambiguity in defining the anatomy. The third and the foremost important point is safety, which means the septal puncture should be performed in a protocolized fashion, the way we have delineated the Pitlock protocol, in which the echocardiographer initially practices the patient's specific views, then identifies the needle, then tracks it all the time visually, then locates the indentation, and specifically when the indentation has been once located, it should always be kept into view, because losing that view for the proceduralist can sometimes lead to inadvertent drifting of the needle and a puncture at a site which is not ideal for that specific left-sided intervention, as happened in this case when we had to revise the transeptal puncture.